What is pain? Pain is a feeling that is produced when tissues are damaged. The brain interprets the signals that are sent from the damaged tissue and produces the sensation of pain. Pain can vary in intensity from mild to severe. It can also be described as aching, throbbing, sharp, or numbing. However, pain is not only physical because a sensory experience can also be due to mental health conditions such as depression, anxiety, or anger. Therefore, a difference exists between pain and the cause of the pain. The link between the two is mediated by our nervous system through a process known as nociception. It was estimated that 20.4% of adult individuals had chronic pain and that 7.4% of adult individuals had chronic pain which limited their activities, such as working, in the past 3 months. What is nociception? Nociception is the process of sensing pain. This can be done through the activation of special nerve cells called nociceptors. These cells are responsible for detecting potentially harmful stimuli, such as heat, chemicals, or injuries. Nociception is important for protecting the body from further damage. What are nociceptors? Nociceptors are sensory neurons that respond to damage or potential damage through alerting communications to the brain and spine. Nociceptors can be mechanical, thermal, mechanothermal, polymodal, or silent. Mechanical nociceptors respond to mechanical damage or pressure, while thermal nociceptors respond to cold or hot temperatures. Mechanothermal nociceptors respond to both mechanical and thermal stimuli, while silent nociceptors respond to inflammatory mediators. What are the types of pain? 1. Acute pain. Acute pain is caused by spasms of skeletal muscles and the activation of the sympathetic nervous system that is due to an injury or a trauma. The duration of the pain is short and disappears with the healing of the injury. 2. Chronic pain. Chronic pain is also caused by an injury or a disease, but the pain would continue even after the healing period. 3. Nociceptive pain. Nociceptive pain is caused by an injury, trauma, chemicals, or surgery that results in the activation and release of inflammatory mediators by nociceptor neurons which activate the inflammation in the injured area. 4. Neuropathic pain. Neuropathic pain is due to direct damages or compression of the sensory nerves associated with sciatica, neuropathies such as phantom limb pain, Wallerian degeneration, segmental demyelination, or diabetic neuropathies. What are other classifications of pain? Other classifications include 1. Allodynia. Allodynia is a pain that is caused by a stimulus that is not the one that initiated the pain, such as feeling pain after a gentle shake of hands or light touch on the back. 2. Analgesia. Analgesia is characterized by the inability to feel the pain caused by a stimulus that should normally have caused pain. 3. Hyperpathia. Hyperpathia is a neuropathic pain characterized by an abnormal, repetitive, and elevated pain reaction to the stimulus. 4. Causalgia. Causalgia is neuropathic pain that combines a sensation of burning pain, hyperpathia, and allodynia. 5. Dysesthesia. Dysesthesia is an unpleasant and abnormal sensation such as cold sensation, tingling, burning, numbness, tickling, or pain that is caused by nerve trauma or irritation. 6. Hyperalgesia. Hyperalgesia is characterized by an abnormally increased sensitivity to pain due to the release of inflammatory hormone-like substances, known as prostaglandins, that increase the sensitivity of the nociceptors. Hyperalgesia can be caused by fibromyalgia, diabetes, infection, trauma, postherpetic neuralgia, and complex regional pain syndrome. 7. Hyperaesthesia. Hyperaesthesia is characterized by an increased sensitivity to stimuli associated with senses such as hearing, tasting, touch, and smelling. Hyperaesthesia is caused by excessive stimulation of the nervous system such as overconsumption of caffeine. 8. Hypoalgesia. Unlike analgesia characterized by the inability to feel pain, hypoalgesia is associated with a reduced response to a painful stimulus. How is pain diagnosed? The symptoms of pain are categorized corresponding to the pain intensity, duration, and pain-related disability. These categories allow the classification of pain into mild, moderate, or severe using the following assessment methods. 1. Visual analog scale. This method consists in drawing a line between 2 points. The first point is the no pain and the second point is the as bad as it could be. The individual in pain is requested to mark the level of pain within the 2 endpoints. 2. Graphic Rating Scale, GRS. This method represents a drawing of a line with levels from 1 to 10 representing the intensity of pain. No pain is represented by the number 0 and as bad as it could be is represented by the number 10. The individual in pain is requested to indicate the number from 0 to 10 which represents the level of pain experienced by the individual. 3. Verbal Rating Scale. This method evaluates the pain experienced by the patient using adjectives to describe the level of pain. 4. Pain Drawing. In this method, the patient is requested to indicate the location of the pain on a drawn human body. 5. McGill Pain Questionnaire, MPQ. This questionnaire assesses the pain rating index, the number of words describing the pain, and the level of pain on a scale of 1 to 5. How is pain treated? Pain is mainly managed through nonpharmacological management and pharmacological management. Nonpharmacological management involves exercise such as swimming, walking, yoga, Pilates, and exercise bike. Physical therapy through physiotherapists and occupational therapists who will help with stretching and pain-relieving exercises. Psychological management through social support, psychologists, and psychotherapists. Pharmacological management is used for mild and moderate pain and involves non-opioid analgesics such as nonsteroidal anti-inflammatory drugs, NSAIDs, and acetaminophen. Although there is a high risk of dependency, opioid analgesics, example morphine, are used for the treatment of severe pain. In conclusion, although the risk factors in the progression from acute to chronic pain are well known, identifying patients who are predisposed to this progression through assessing the status of the acute pain, the physiological and reactivity of the patients to pain, should help better manage the switch from acute to chronic pain. If you enjoyed the video, please like, subscribe, and share for more videos like this.